Morning to all. I am discussing the role of azathioprine versus mycophenolate Mofetil in autoimmune hepatitis. So my discussion will be within these headings. So I will discuss briefly about basic pathophysiology of autoimmune hepatitis, diagnostic algorithm of autoimmune hepatitis that is already discussed, and standard first line treatment, few of the second line treatment option, comparing azathioprine versus MMF in autoimmune hepatitis. So, coming to the basic pathophysiology of autoimmune hepatitis, the autoimmune hepatitis is a complex interplay between predisposing factors like genetic predisposition and environmental factors like triggers in the
Babu,
form of.
Dr. Babu is little. I should not be interfering, but the first two, three parts are going to be repetition. So if you can go faster
Yeah,
to
I think I can
manage. Yeah.
skip all these. So diagnosis is already covered. So I am directly coming to few of simple case scenarios. So case one is a 39-year-old female patient who is already known case of hypothyroidism, now presented with fatigue and nausea for 1 month. Her investigation revealed high AST/ALT and normal alkaline phosphatase with normal bilirubin. Autoimmune markers were positive, ANA 1:160. Also, she has high IgG, and liver biopsy showed lymphoplasmacytic infiltration and presence of interphase hepatitis. So, diagnosis of autoimmune hepatitis type 1 can be reliably made based on these findings. But what should be the standard approach for these patients? The guideline is very clear, but previous studies showed that there can be 4 types of approach. Number one, we can give steroid alone. Number two, steroid followed by azathioprine. Number three, steroid plus azathioprine or azathioprine only. So treatment guideline, both ASLD and EGL guideline, that is published in 2020 and 2015 respectively, they showed that in patient with uncomplicated autoimmune hepatitis, the ASLD guideline says that is starting of prednisolone with dose of 20 to 40 milligram per day, and followed by adding of azathioprine after 2 weeks of starting of steroids, or alternatively we can consider use of budesonide, that is 9 milligram per day, and checking of the remission in the form of biochemical response at 4 to 8 weeks, then taper the steroids with 5 to 10 milligram per daily, and maintain the azathioprine up to 150 milligram. So what is the goal of biochemical remission? As per the latest criteria of published in 2010, the biochemical remission is redefined in the form of normalization of the liver enzymes, that is less than 19 and less than 30 in females and males respectively, and normalization of the serum IgG within the normal limits, with reversal of the histological markers in the form of lymphoplasma cytic infiltration, and reversal of interphase hepatitis. The use of prednisolone there is a specific population like patient with autoimmune hepatitis with cirrhosis. Here we cannot use budesonide instead of prednisolone, because budesonide in these patients can cause portal vein increased risk of portal vein thrombosis, or patient with cases of HOTO is also reported when we use budesonide in patient with autoimmune hepatitis and cirrhosis. Similarly, budesonide and azathioprine is not recommended in patient with acute severe autoimmune hepatitis. We should check, as per the ASLD guideline, we should check TPMT levels before adding azathioprine after 2 weeks of starting of the steroids. So this study, this meta-analysis of two studies that compared prednisolone and azathioprine versus budesonide and azathioprine. In this meta-analysis, ultimately they included 2 studies, and the study done by Mann et al. That was overweight as compared to other study, and this study showed that using budesonide and azathioprine had favorable outcome in patient with autoimmune hepatitis in the form of better remission rate and better survival. Another study of 107 patients in autoimmune hepatitis, they measured serial IgG levels, and that showed that normalization of IgG levels at the end of 6 months or 1 year is predicting of biochemical response and predicting of survival, and this study showed that treating of the cirrhotic patient also improved the survival of autoimmune hepatitis. So this is the outcome of autoimmune hepatitis from UK group of 28 centers. They compared the dose of prednisolone, dose of initial prednisolone, whether it was used more than 35 milligram or less than 35 milligram. They showed that there was no difference on the survival when there was difference in the dose. Similarly, using budesonide versus prednisolone, there was no difference in the survival. Also, duration of the steroids, whether it was less than 6 months or more than 6 months, there was no difference of the survival along with azathioprine. Only difference of the survival when whether azathioprine monotherapy was given or it was combined with steroids. So the patients who received combination therapy in form of prednisolone and azathioprine, they showed better survival in the follow-up over 12 to 14 years as compared to when there was no steroids was given. So coming to azathioprine metabolism, azathioprine is a thiopurine prodrug. This gets converted to 6-mercaptopurine in the blood and ultimately metabolized to the thioguanine. This is the active molecule that is responsible for the immune suppression. Azathioprine toxicity is common. The dose-dependent toxicity occur in the patient with TPMT deficiency, that occurs in around 0.3% of the population, and this TPMT deficiency cause decreased metabolization of the 6-MP to methyl mercaptopurine and divert more 6-MP to the thioguanine nucleotide. So this molecule is responsible for the dose-dependent toxicity of azathioprine in the form of bone marrow suppression. Other toxicity of the more common occurring toxicity of azathioprine is idiosyncratic reaction. These occur in the early course of within 1 month of starting of azathioprine and more common as compared to dose-dependent reactions. So I am continuing with the same case. The same case was started on prednisolone and azathioprine of 150 milligram per day. After a month, that patient presented in emergency with acute abdomen in the form of pain abdomen, vomiting and nausea, and his liver biochemistry was normal, but there was elevation of the amylase and lipase. CT scan also suggestive of evidence of acute pancreatitis. So azathioprine related pancreatitis is azathioprine is considered definite cause of drug induced pancreatitis. This complication occur within weeks to month of starting of azathioprine, occur rarely in less than 5% of the population of who receive azathioprine. The exact mechanism is not known, but females are more prone and children and older people more than 60 years. These are the prone population for acute pancreatitis related to azathioprine. So I am describing another simple case of 50-year-old male presented with abnormal liver enzymes, and his workup showed presence of autoimmune hepatitis. He was also treated with prednisolone and azathioprine. After 1 month, he also landed with another problem like high spiking fever up to 103 degree Fahrenheit with tachycardia, but there was no evidence of sepsis or any viral infection. In this patient, azathioprine was stopped. Following that, fever was resolved and there was no recurrence of the fever. And so this is also a type of idiosyncratic reaction that is very common in patient who receive azathioprine. So this is hypersensitivity reaction that occurs because of inactive metabolite, and inactive purine based metabolite, and it doesn't occur with 6-methyl mercaptopurine, can occur within days of starting of azathioprine. It may be associated with rash, nausea, diarrhea and high enzymes, and may mimic as other viral infection or viral hepatitis. The problem is re-challenge of azathioprine may cause recurrence of the febrile episodes. So the idiosyncratic reaction of the azathioprine are the most common cause of adverse events, and another problem is cholestatic injury that is very less common, occur in 0.1% of the patient. Patient present with mixed cholestatic and hepatocellular injury. Biopsy showed bland cholestasis and minimal inflammation. This resolved with discontinuation of azathioprine, but case reports of progressing to vanishing bile duct syndrome also described in the literature. Coming to dose dependent azathioprine toxicity, this occurs in the patient with complete TPMT deficiency that occurs in around 0.5% of the population. So, it also associated with certain interaction with certain drugs like allopurinol and febuxostate that inhibits the xanthine oxidase enzyme and diverts the 6-mercaptopurine to methyl mercaptopurine. So, and the thioguanine. So, this dose dependent toxicity cause myelosuppression and hepatotoxicity, myelosuppression of leukopenia and thrombocytopenia, and hepatotoxicity in the form of mild elevation of the enzymes within first 12 weeks of treatment. This is self-limited problem resolved with decreasing the dose. So, early discontinuation of azathioprine can occur in about 10 to 20% of the cases, and mostly it is because of idiosyncratic adverse events, and there is no difference of the adding azathioprine in the early course of the steroids or late course of the steroids. So, when to avoid azathioprine? The patient who had pre-existing cytopenia, patient with hypersplenism, complete TPMT deficiency, prior azathioprine intolerance, and so this is the important population we should avoid azathioprine. And also with certain drugs like warfarin and angiotensin converting enzyme inhibitors, because in warfarin along with warfarin this cause a decreased anticoagulation effect. Approach to non-response of the first line therapy can be is reported in literature in up to 50% of the patient with combination of prednisolone and azathioprine. And this non-response of first line therapy is associated with increased incidence of cirrhosis and need of liver transplantation or liver related events in the follow-up. So, approach to non-achieving remission, first we should look about the compliance of the treatment, and if the compliance is adequate, then we should rethink of the diagnosis. If the diagnosis is also correct, then we can check the metabolite level in the form of 6-MP and 6-thioguanine, whether these are in the adequate level in the blood. An interesting approach has been described in the literature is in the form of inhibiting the xanthine oxidase enzyme. So, this blocking of this pathway, this leads further metabolism of the 6-mercaptopurine to the active metabolites of in the form of 6-thioguanine. So, this interesting study of 59 patients, they use allopurinol at the dose of 100 milligram per day, and they found that within a few days of starting of allopurinol, there was decreased level of inactive metabolites of azathioprine in the blood. Also, there was increased levels of 6-thioguanine in the blood, and it was associated with decline of the liver enzymes, decline of the ALT within 1 month of follow-up after starting of the allopurinol. So, what are the alternative options? The main alternative options are mycophenolate, mofetil, and tacrolimus cyclosporin. So, MMF is the most commonly used second line treatment for autoimmune hepatitis. When it was used as a second line treatment option in patient with whether azathioprine intolerance or non-responders in around 82 and 32% of the patient. This study of this meta-analysis of 12 studies of 397 patients, they showed that biochemical remission with switching to MMF was seen in 58% of the patient at follow-up of 6 months. And there was minimal adverse effects, and adverse effects causing drug discontinuation was just in the 14% of the patient. So, this study favors the use of mycophenolate mofetil as a rescue strategy in the patient who are not responding to the conventional regimen. So, what about MMF as first line therapy? So, there are multiple small studies has been published in the literature using MMF as first line treatment. So, this study of 16 patients who received steroids and an MMF is at start. This study showed, this is the retrospective study, this showed that there was high biochemical remission noted in up to 84% of the patient, and around 34% of the patient had some sort of intolerance. So, a study compared MMF and azathioprine in the this cohort contains 36% patients of cirrhosis. They found that MMF is associated with higher rates of remission, that is 93%, as compared to azathioprine, that is just 45%. Interestingly, withdrawal of the MMF was associated with persistent remission in around 75% of the autoimmune hepatitis patient. That is quite high as compared to azathioprine. So predictors of sustained response after MMF withdrawal was longer treatment duration with MMF, higher ALT level at baseline, and lower IgG level at baseline and 6 months of the treatment. Caveat to this study is this is a single center study, non-randomized, and includes a small sample size. So what about another study? This study also showed that complete biochemical response at 12 months was significantly higher in around 86 and 71%, as compared to azathioprine. This was just around 43%. So MMF has been proven as a more effective drug and associated with less complication, like in 3.8% as compared to 18.8% in azathioprine group. The patient with cirrhosis also showed better survival when they were treated with MMF and steroid, as compared to when there was no treatment in cirrhosis and autoimmune hepatitis. So this study, including MMF, comparing MMF and azathioprine. So this is the propensity matched trial of MMF and azathioprine. They showed of 32 patients in the each group, they showed that complete biochemical response at 6 and 12 months was quite high in MMF group, up to 97%, and in azathioprine group just 68.8%. So another meta-analysis of studies of MMF versus azathioprine, this meta-analysis showed that is the persistent biochemical remission was higher in MMF group, and decreased normalization of the IgG level was also higher in the MMF group as compared to azathioprine, and no response or no biochemical response was seen mainly in the azathioprine group and as compared to MMF group. So this meta-analysis showed the maximum response of the MMF in maximum response of autoimmune hepatitis in MMF group was up to 86 to 90%, as compared to 40 to 50% in autoimmune hepatitis group. So this is the latest published randomized control trial published in Journal of Hepatology, including 70 patients. Those who were treatment naive autoimmune hepatitis received either mycophenolate, Mofetil, or azathioprine in combination with similar dose of prednisolone, followed for 24 weeks. This was open label RCT, and primary endpoint was biochemical remission that was defined as normalizing serum level of ALT and IgG after 6 months of the treatment, and secondary endpoints include safety and tolerability. So this study showed that primary endpoint was met in 56 and 29% of the patient in MMF and azathioprine group respectively. MMF group had a higher complete biochemical response, around 72%, as compared to 32% at 6 months in azathioprine group. There was no serious adverse event in MMF group as compared to azathioprine group, and treatment discontinuation was also low in MMF group. Still there are, this is also, though this is a randomized control, only published randomized control trial, but there are few caveats like higher ALT in azathioprine group, and TPMT levels were not done in this study, and we need a large database is required to evaluate the late adverse effects of MMF. So what are the issues with MMF? First is high cost, and this is a teratogenic molecule for fetus, so not suitable for women in with autoimmune hepatitis in pregnancy, and we need more large database for a longer duration of the with the mycophenolate Mofetil. The US FDA recommends that female patient must have negative pregnancy test before starting of MMF, and they should use at least 2 methods of contraception while they are on MMF therapy. So, what is the implication of liver biopsy when the patients are already on biochemical remission? So, this study published in American Journal of Gastroenterology, they showed the patient who had persistent normal liver enzymes. So, biopsy was done in this patient, and they found that around 46% of the patient had still persisting histological activity, and this is the population that progress less frequent regression of the fibrosis in 32% as compared to 60% in the those who has no histological activity. Also, persistent histological activity was associated with higher mortality in patient with in this cohort as compared to no histological activity. So, this is a interesting study published by International Autoimmune Hepatitis Group. They showed that patient who received immune suppression when the AST/ALT level was declined with more than 50% at a follow-up of 1 month. So, this is the patient population who is likely develop normalization of the LFT at 6 months, and this same population develop normalization of the IgG at 6 months, and these are the patients who had who achieve histological remission in the follow-up. So, the kinetics of biochemical not only determines about the response, persistent response, but also determines about the liver related death, that is higher in patient with non-responder as compared to responder. Withdrawal of immune suppression, relapse occur after rapidly after treatment discontinuation, and the incidence of relapse or loss of remission occurs in around 59 to 81% of the patient at 1, 2 and 3 year of the follow-up after treatment withdrawal. In patient with combination therapy, when the patients are in combination therapy at the time of withdrawal, there is high risk of relapse as compared to monotherapy, and time to relapse was also shorter in the combination group. In the literature, the majority of the studies assess biochemical response only. The paired biopsy was not done. The histological assessment is the key to deciding about remission, because around 50% of the patient they may still have histological activity of autoimmune hepatitis. A large database with a longer duration of follow-up is required with mycophenolate Mofetil as
Dr.
first line.
Meena,
The goal of treatment is to achieve biochemical remission and halt the progression of liver disease and histological remission. The intolerance and non-response to conventional first-line treatment is seen around 20 and 50% respectively. MMF have better tolerability profile, and can lead to fast remission rates of autoimmune hepatitis, and this can be better option in patient who have low TPMT level, persist pre-existing cytopenia or hyperinsulinism. Thank you.